Welcome to Women in Research. My name is Astane Kesa. I work in the Directorate of Corporate Affairs Office in the University of Nairobi. And with me today is Dr. Lois Ombajo. I will let her give us more details about herself and then we go on from there. Karibu, Dr.
Thank you so much, Nekesa. So as you rightly said, I'm Lois Ombajo. From the Faculty of Health Sciences. I teach in the Department of Clinical Medicine and Therapeutics. I also co-direct the Center for Epidemiological Modeling and Analysis.
Yes.
Big mouthful.
Yes.
But beyond the teaching and clinical care, I'm an infectious disease specialist. So I provide infectious disease care to patients at the Kenyatta National Hospital, which is the teaching hospital of the University of Nairobi. I'm also a researcher, doing quite a broad range of research at the university.
Yes. You will tell us more about it, but before we delve into it, there's a big achievement. You've been published, or you're about to be published in the New England Journal. Is it the New England Journal?
Yes.
You can please tell us more about it, shed more light on it, and what your article was about.
Yeah, so thanks for the opportunity to talk about it.
Yes.
So this morning we had a publication in the New England Journal of Medicine, and really, really excited about it. The New England Journal of Medicine is probably the most prestigious medical journal in the world, and it's not easy to get a publication in there. So there's some research that we've been conducting, and I could tell you a little about it.
Yes,
and
please.
even the process that led up to this publication. So actually, at the beginning of 2020, we started on a clinical trial. This was my very first clinical trial.
Okay.
And 3 months after we started, COVID came. But that's a story for another day.
Yeah.
We still managed to finish the study. So clinical trials are interesting. They're probably one of the highest levels of evidence that can be generated to inform practice. And what happens in the clinical trial is we enroll participants. Participants could be patients or other people who are of interest in the research area that we're looking at, practice. And for this particular clinical trial, we call it the 2SD trial. It stands for second line switch to Dolutegravir.
Okay.
So this was a trial on HIV treatment. And the reason we did this is that we are constantly looking for better ways to treat our patients, treatments that improve the outcomes of patients. So when we're treating our patients, we often have patients who've been on certain drugs, and we're trying to see whether newer drugs or alternative drugs would lead to better outcomes. And you can't just get up one day and say, I think I'm going to change your treatment to this. We need evidence to support that care. So in Kenya, and in many contexts that are similar to Kenya, we use certain drugs called protease inhibitors to treat patients on second line of HIV treatment. And second line means that we've treated you with a first line regimen before, which failed, and now we are moving on to a second line. And we've used these drugs called protease inhibitors for a long time. Patients do very well on them, but occasionally we struggle with side effects. We struggle with, which other drugs we can use together with these second line drugs, because they may interact in ways that are unfavorable. But these protease inhibitors are also a bit more expensive for programs. So the question was, can we use a more recent drug in the market that we call Dolutegravir, which is ordinarily used for first line treatment, but we haven't studied whether switching patients who are already on a protease inhibitor to Dolutegravir will be as good, if not better, or what we say, not any worse than what they were on. So the question that we're asking was, is it safe to switch patients on protease inhibitors for second line to Dolutegravir? Is it safe? Does it work? Will the outcomes not be any worse than what they're already on? So for us to answer this question, one, we had to write a very big research protocol. We had to look for funding, and we're very fortunate to get good funding to conduct this study. The funding was provided by one of the bigger pharmaceutical industries called Viv Healthcare. And we also needed to recruit participants. So for this, we recruited participants from HIV clinics at the Kenyatta National Hospital, at the Jaramogi Oginga Odinga Teaching and Referral Hospital in Kisumu, at the Thika Level 5 Hospital, and the Kiambu Level 5 Hospital. We had a total of 795 participants from these 4 sites. And we do something we call randomization. So we randomize someone to either continue with their protease inhibitor or to switch to the Dolutegravir. So you are, we tell you about the study, and if you consent and are willing to participate, then you are randomized to one of those. You don't get to choose, and you don't choose so that we avoid bias. With the clinical trials, you have to be sure that the results you get are not biased by anything. So that's why we randomize. So we randomized half of this group to the protease inhibitor to continue with their treatment, and the other half was switched to Dolutegravir. And we followed each participant up for a period of 48 weeks.
Wow.
And during these 48 weeks, we'd see them frequently, see if they're having any side effects, see what their viral load, which viral load is a measure of how well the HIV is controlled. So what their viral load was, and whether there were any complications of the switch. So we did that periodically over this period, and at 48 weeks we were able to demonstrate that switching to Dolutegravir was not inferior to continuing, which means patients did well, and it was also safe. So what does that mean for one, the Kenyan HIV national program, but also a lot of national programs, even for the World Health Organization guidelines, that we can now issue guidelines saying that for any patient who's on a protease inhibitor based second line, they can actually switch to Dolutegravir, which will work well in terms of suppressing the virus, is safe for patients, is easier to take because it's just a single pill compared to many of the protease inhibitors that may be anywhere between 2 to 6 pills, and is cheaper for national programs. So it's cost effective, exactly. So it was excellent results. We got to present them in an international conference last year, the Conference of Retroviruses and Opportunistic Infections. And once we presented the results, there was also a lot of interest around it, and we decided to try and get it published, which often is every researcher's dream, to get your work published. But we also aimed very high. We went to the very top of the publication ladder, and we submitted our manuscript to the New England Journal of Medicine. It's been a long journey. After we submitted, it had to be reviewed. We got back review comments that we had to respond to, had to clarify, correct some areas. We also deposit all the data from the clinical trial in what we call a public repository. And this allows other investigators to look at your data and confirm that you not just sat somewhere and cooked up something, that it's actually real,
did it,
and you've made the right conclusions out of that data. So it's been a long journey. It was finally accepted by the New England, and there's been a bit of editorial work around it, and finally we're informed it was going to be published, and that was done today morning.
Congratulations. That's a long story, but I've picked, and since it's the first time I've also had it, in terms of percentages, maybe I like the fact that you picked random, so no age, no gender, no word in terms of.
So it was for adults, so adults above the age of 18. Of course, going forward, the question will be, can we try the same in younger age groups? Often many clinical trials start with adults just because the complexities of enrolling children. Then we also had, the population was very representative of the Kenyan population living with HIV. So about close to 60% were women above the age of 18. Our median age was about 46, which means a few people above that, some were below that, but around the 40s, which again is a reflection of the population living with HIV in Kenya.
Wow, congratulations. Now, in general, what does this mean for you as a researcher in terms of HI index? I know for us, that's, what we know and we look out for, citations, HI index.
So as a researcher, and it's for us, a lot of our research is not individual. So we work as a team of many researchers. And actually, if you look at our publication, we're a big team of other specialists in the area. So one, it's a good thing for the whole team, not just for me. And it was an excellent team that we worked with. And what this means for research is that, one, you have the best way of actually letting people know about your work.
Sure.
because the best research is the one that impacts people's lives. And sometimes if you keep it, it's not impactful.
Yes.
So in this one, we have it out there. People can refer to it.
Yes.
Actually, one of the things that happened even before the publication is that if you look at the US International Society for AIDS guidelines,
Yes.
they've actually referred to this work.
Wow.
If you look at the British HIV Association guidelines, they've referred to this work, and it's formed part of their evidence base for developing their guidelines.
Yeah.
So I'm sure even for the Kenyan national guidelines, as we're rewriting them, this will be part of that evidence base. When the WHO is rewriting their guidelines, this will be part of the evidence base. So it's not just for the Kenyan population, it's informing practice in the US, it's informing practice in the UK, and it's going to inform practice in a lot of other countries around the world. So that's fantastic, because the reason for doing research is to impact people's lives positively.
Sure.
So if we can do work that ensures that patients have better treatments, then that really is a joy for us. So I think that's a first thing for us as researchers, that we're contributing positively to care.
Yeah.
But of course, it's also good for the networking with other researchers. Ever since we started, we've gotten a lot of people coming to ask if they could collaborate with us in other research. I conduct other clinical trials and other research, and increasingly people from other continents, be it from the UK or the US, are saying, we have this, would you like to partner with us? So it also opens up our space and the university as well for collaboration with other institutions internationally. And of course, it adds to a profile as a researcher. You know, when you have not just a publication, but such a high-level publication, then it also raises our profile as researchers. And that brings with it, as I said, collaborations. Hopefully, it also opens us up for further funding.
Sure.
Yes.
Congratulations again, Dr. So 2 questions that are coming to mind. Should I merge them or separate them? So there's this accusation about African researchers that now that you are published, you know, in the New England Journal, and we are here and you're practicing here, how much of access can you generally comment on Kenyans and accessing, 1, your research, and 2, the outcome?
So that's one of the things that we're always very conscious about. It doesn't make sense to do research that does not impact the population in which the research was done. And many times we have discussions with international researchers about wanting to do research that informs something but not here. So for us, this was probably one of the biggest clinical trials done in Kenya by Kenyans.
Yes.
So that's a big deal. I sit in the working group that writes the national guidelines for HIV treatment. So this can already clearly be translated because we're able to provide that evidence to this working group.
Yes.
The other thing is that we publish in a journal that's open access. So the New England Journal of Medicine can be accessed without the need to pay for it.
Okay.
So that's a good thing. There are a lot of journals where you have to subscribe or something like that. So for this one, the access is free for people in resource-limited settings such as ours. So that's accessible to not just patients and patient advocacy groups, but also to other researchers, to guideline development groups. It's something that's accessible to them. And as I said, the data that we have is actually deposited in a public repository, which means other researchers can analyze it, can use it for their own research work. All they need to do is to write and say, can we use this data for something else? So the data is not hiding, it's in a public repository. And maybe as I say that, it's important to say that when it's in a public repository, it cannot identify anyone. We call it de-identified data. So there's no fear that the data can be linked to any individual.
Okay. Oh, wow. That's good to learn. That's first and foremost. Was it yesterday? Okay. By the time it comes out, it won't be yesterday. But I was listening to Dr. Atul Gawande yesterday, and he was talking about universal health coverage. And he used Kenya to, as an imprint that the USAID are going to use Kenya as a low and middle income country to try and support us in terms of achieving the universal health coverage. And these are some of the issues that we were talking about, that community-based healthcare should start from there, as then it replicates and it's scaled up to now being able to, for everyone to be able to access what is, the best out there. So you've assured us rightly that we are lucky that you are our researcher and you're sitting in those, policy where you can affect policy. But then again, how does it get to the community? Now the community-based healthcare workers, and just comment first before I ask the next question.
Okay, that's interesting. I mean, universal health coverage is what we really aspire to. And I think for us to attain universal health coverage, we have to find the best treatments that are most cost effective so that they're affordable for governments. Because at the end of the day, it's governments providing healthcare. So I think this is one of those that actually pushes the envelope towards there to say, how can we ensure that the treatments we use are the most cost effective? So that's one. The other one is that part of the national HIV program is actually around training healthcare workers. And we've been, even from the University of Nairobi, been very involved in developing curricula as well as in rolling out training for healthcare workers. Because again, we talk about something called differentiated care, where for HIV care we ensure the nurse can provide the care, the clinical officer can provide care, the doctor or the specialist can provide the care. So for us, it's around having very clear guidelines that's informed by clear evidence so that anyone along this chain of supply of providing healthcare can actually refer to those guidelines.
All right. And from now, in your own, for other young women researchers or other researchers that may want to follow in your footsteps, how long have you been in the HIV space in terms of research? Where did you start from? And in terms of milestones, where is this placed?
Okay, so in terms of HIV care, I provided HIV care for a number of years. It started by one, just making sure you provide excellent care, making sure you're very well read so that you're always using evidence to inform your practice. Then I was asked by the National HIV Program, call it NASCO, to join some of their technical working groups around managing complex patients. So they'd send questions on complex issues for which you require to, give it a bit more technical input and also to help with the writing of the guidelines. So all this you do out of service for Kenyans because it's not work that's paid for. And I think that's where it starts from. The passion to provide and give your very best, irrespective of whether someone is paying for it. In writing guidelines, we actually it has to be evidence-based. And what actually informed this trial was we're writing guideline around these patients who are on a protease inhibitor. And we were wondering about situations where we needed to change their treatment. For example, if they had TB, they couldn't use protease inhibitors unless you change the TB medicines, which again, those alternative medicines are not available. So the question was, can we just switch? And initially we did switch some patients without the evidence because we were between a rock and a hard place. But as we were writing that, we're like, surely there has to be evidence for us to decide what to do. But there was none. I remember sitting with a colleague of mine, were like, why don't we do a clinical trial? And
instead of just writing,
instead of just saying, let's do this because we don't have anything else. So we wrote a concept. And I remember talking to some colleagues and saying, I'm really looking for funding because this will take quite a bit of money. And, one of my colleagues said, why don't you send us a concept and we will see. And this was in 2019, I think. That was really the first time we did any HIV-related research. So we wrote the concept and I sent it to them. And after a while, they came back and said, why don't you give us a full proposal? And they're like, okay, that's a good thing. So we wrote a full proposal and submitted to them. And they had a lot of questions. They said it has to be reviewed by their scientific leads in Africa, in the bigger region, and then the International Scientific Committee. And they kept asking for more and more questions, really making sure we'd sharpened our ideas. It wasn't just a vague thought. I remember going for one HIV conference and said, since you're there, why don't we meet you? We had a few questions. It must have been a sort of interview to see, is this person real? And do they know what they're talking about? And soon after came from that conference in 2019, they said, yes, we'll give you the funding. And it was quite a lot of funding. For this work, they gave close to $1 million plus some of the medicine. And that money doesn't go to the researcher. So all our funding comes through the University of Nairobi. And this is what goes into paying for all the lab tests, paying all the staff because we needed nurses and clinical officers. We needed a lot of, patients come and go. We need to pay for their transport. So all the lab tests we need to pay for. So that money goes into paying for the actual research. And so we finished We finished it well, and then the rest is as I told you. And in the process of doing that, we're now actually running another clinical trial, and hopefully we'll have a publication of the results maybe sometime either later this year or next year. And our colleagues from the London School of Hygiene and Tropical Medicine approached us and said, could we run a clinical trial together? So we're looking forward to starting that in the next month or so. So it's sort of just been a journey.
You said something very, very interesting, that you were given this role and then it inspired the research. I wish someone can pick it, because so many people are in these subcommittees and they're in these policy writing positions, and you wonder whether they, tempted to take the shortcuts to just write the guidelines either without evidence or something. But I picked that up. That was very powerful. So do you want to tell us maybe something from the infectious, you said you work in the infectious diseases, and at the time you were among the people who are advising, Kenya government during COVID. Some background on that.
That's an interesting one. At the time when COVID came up, it was a very scary time. No one actually knew what it was. And I'd been asked to lead the KNH infectious disease unit. Mainly because there were very few infectious disease specialists in the country, and they thought I would provide some leadership and take care of patients in the unit at the time. So when COVID first came, we were the ones who were, screening the very first people traveling into Kenya who had symptoms suggesting of COVID, who were struggling to give some direction. And everybody started saying, this is the expert. And I'm like, no one is an expert in COVID because it's new to all of us. But I think there was a lot of reading, a lot of learning. I treated a lot of patients with COVID when we had to dress like we were going to space because everybody was so scared. No one knew the right thing to do. So I remember screening some of the first patients, helping to manage some of the first patients together with an excellent team at the University of Nairobi and at the Kenyatta National Hospital. And I think we learned a lot in that process. There was a lot of meetings with the Ministry of Health because they asked us to help advise. At SEMA, which I referred to earlier, the Center for Epidemiological Modeling and Analysis, together with my co-director, who's called Thumbe Mwangi, we started talking about how best can we inform Ministry of Health. So we started doing some, reviewing the data and doing some modeling so that we could have some projections. What should we do? What is the right response? We started with the Ministry of Health, the National Emergency Response Committee, the presidency, and we were called upon at different levels to advise, and also led sort of the writing of the guidelines for management of COVID-19 in hospitals. But we also did a lot of education for healthcare workers. I remember together with my colleagues, we ran a webinar for 2 hours every Friday for close to 2 years. And we'd have more than 1,000 people logging in every single week because people were hungry for knowledge. It was a scary moment.
We were scared.
So, it was interesting. I think we've come out stronger. Our public health systems will be a bit stronger, but I think the healthcare worker has come out very resilient as well. We're not as scared as we were then. And even with new things, I think people will be more willing to provide care. Remember when I started, we're like, you're not scared, you'll get sick. Everybody was very scared. So I think with this one, people are now, if something else happened, I'm sure people will be more willing to put themselves out there and provide care. But I think I salute a lot of healthcare workers because despite the fear, people did their best to provide care.
Okay, so then how do you go back and take care of yourself, doctor?
That's an interesting question. So I remember during COVID, so my family is really my rock. They're the ones who will listen to me, will be worried when I'm late because they know I'm in the unit, will be listening to every phone call. They listen to a lot of Zoom meetings with the Ministry of Health during that period. I know they know Sunday morning would be wanting to do something, then suddenly I'm running out and they don't know what time I will come back. So my family was extremely supportive. I have to really salute my husband. He was such a rock during that entire period. We spent a lot of time as family, and I think we grew a lot as a family because that's all we had during that time. So I think a lot of my me time is spent with my family. I'll go out with my friends once in a while. I like to read. I work a bit too much.
Yes.
With all this research, a bit too much reading and writing.
Yeah.
So I work a lot, and hopefully, I think my dream is that we have a lot more younger researchers coming in, taking our scientific leadership, so that they're also able to run with this. I think one of the challenges I work with a very big team of excellent young people who do most of this work. Actually, most of the credit is to this team of young people.
Yes.
And I'm hoping that they grow to a point where they're not just doing because I said, do this, but they come with their own ideas, and they go, they grow in their own direction. They get their own brands. They write their own papers. So we're really working on mentoring younger people to get to that point.
That was going to be my next question. Okay, can you give us maybe your learning, your best, I want to say it like a learning, like something you can teach us from your own philosophy of life.
Okay. I guess my philosophy actually comes from the Bible. I think it's in Colossians 3, where it says, whatever you do, do it as unto the Lord. Like, if you're given something to do, do it like God himself was watching you. Do it like your life depends on it.
Okay.
Because with that, with our passion, with our commitment, those are the things that are the most successful. So it doesn't matter if it's a small thing, if it appears, if you're sweeping the floor, sweep it like that's the one thing that matters most in the world. If you're doing research, do it because lives depend on it. When I'm providing care for my patients, I know that their lives depend on it. So I think for me, that's the one thing. Anything you do it to the best of your ability. Take hold of opportunities that come your way, and run with them, because some things knock once and they don't come again. So when opportunities come, make use of them and help to grow other people along the journey.
All right. Thank you so much. What are you scared about most in life and in your research, in your career?
Failing. I do not like to fail. So I'm scared of failing. I'm scared of, actually, before I started doing research, many times you apply for grants for research, and many times you'll apply for many and get many rejections before you finally get one who says yes, we'll fund you. So I don't like rejection. I don't like applying for something
and
even
it doesn't
for
go through.
Sometimes you submit manuscripts to journals and they say no, we will not publish this. The New England Journal of Medicine that has now published this paper. I remember when we did COVID work, I submitted a paper on COVID, and within, I think, 24 hours, I'd gotten the rejection. Like, we are not going to publish this. So it felt bad. And we finally got the paper published by the British Medical Journal. But that felt bad. But I think it's about resilience, and keeping trying and getting better, because you get all those comments and use them to improve your next one, and you improve your next one. So I don't like failing. I don't like to fail.
It's good to know. Does AI technology scare you in any way? Your research work, your fields?
Not necessarily. I think the only thing, I like to interact with people. I like to hold my patient's hand and talk to them. I like to talk to my students. So I think technology scares me in terms of reducing the human touch. I want to still talk to people and do things with people. But beyond that, I think we have to embrace the things that make our work easier, the things that can inform our research even better. I bet 10 years from now, there may be easier ways of doing clinical trials rather than the laborious way we did it. So hopefully, the things that make life and work easier, we should embrace them. So I'm being reminded to ask something. Recently, the university was in a collaboration, the guild, Arua Guild, and you were named as one of we have been selected for Arua Guild. So the Arua Guild is a collaboration between a few African universities and European universities. So the African university and the Arua University. So African Research Universities
Alliance. There's something alliance.
Don't lie to me. I look bad. So the Arua portion is led by the University of Stellenbosch. Then we have University of Nairobi, University of Rwanda. I think University of Cape Town must be one of those. Then from the Guild perspective, we have the University of Bern and a few other institutions in Europe. And the aim is to come together and do research that's impactful, but that also leads to growth of African researchers. So in this Arua Guild, we actually applied to do what we're calling genomics in Africa. So understanding genomics of rare diseases, understanding genomics of pathogens, and we are currently struggling with what we call antimicrobial resistance. You know, bacteria that are resistant to antibiotics, and those are causing a lot of mortality. So can we understand the genomics to help us think around treatment, think about spread and transmission, and how to control that? So we've just gotten through the first stage. We just got the news, I think, last week that our collaboration had been selected for one of those awards, and we're sort of waiting for the next step. It's like this is when the work starts, ensuring we have each of the research areas very well defined, but also ensuring, I think at the end of the day, is ensuring that we have excellent young researchers come out of this collaboration.
Thank you so much, Dr. Any parting shot you may have?
Oh, no, thank you. Thank you for this opportunity to speak. I think my call is really to younger people to ask questions, see problems as opportunities to offer solutions. Ask yourself questions. Don't take things for granted. Ask yourself why. How is this building standing here? You know, and then seek to find answers for the problems that you see around.
Thank you so much, Dr. Thank you for availing yourself, for educating us. I'm so glad we had this talk and we had this chance to talk. That was Dr. Lois Ombajo, a University of Nairobi women researcher who's just spoken to us and given us her research history and her latest HIV breakthrough. Thank you so much for watching. Until next time, have a good one.